So good evening to one and all. So welcome to the journal club this evening. We have Dr. Vani to start the talk on this enigma of pathophysiology of recurrent implantation failure. And we usually don't go into the depth of why it is happening, and we concentrate on what can be done to avoid this. So now we'll have Dr. Vani talk on pathophysiology so that we will know where to address. Over to Dr. Vani.
Thank you, Dr. Indumathi, and welcome everyone for another journal club. Like Dr. Indu said, we have two topics today, and we'll see how much we can discuss about these two topics and understand. Both are very important. My talk is a review of pathophysiology of recurrent implantation failure. It's a review, and which is done by several authors from several universities all over US and few universities in Europe as well. So they have looked into a different aspects of implantation and why implantation can go wrong, and they have produced their review, and I'm going to present only their review. And of course, there are innumerable articles about why an implantation can fail, and then what exactly is recurrent implantation failure, and whether when you will call it a recurrent implantation failure. You know, how many embryos do you have to transfer before you call it as a recurrent implantation failure? Whether you need to consider the ploidy status of the embryos before you can. So the definition is not at all clear. And recently there is an article which says that when you are transferring euploid embryos in an anatomically normal uterus with nicely prepared endometrium, you should have less than 5% of implantation failure. So RIF should be less than 5%. So then what happens to the other factors? So every day it is changing, but it is a good idea to know how many factors are important for this implantation. So I'm going to touch upon all the factors this review has touched upon. Okay, successful implantation is dependent on a competent blastocyst and receptive endometrium and a successful crosstalk. So all these three things should be there. And I said several embryo transfers because the definition keeps changing all the time. Like two IVF failures or 3 IVF failures, just to say, blindly without going into whether it is a blast or a cleavage stage or whether what you have done before the transfer. If you don't take anything into account, just like that, you can say 2 IVF failures or 3 IVF failures. But if you are being very, very specific, then there are people who say at least 3 good blastocysts or 4 good blastocysts in 2 to 3 cycles if you have transferred. And if it's not resulting in implantation, we can call it recurrent implantation. So that is where the current thing stands, but it will soon change because of this people checking for the ploidy status and then transferring the embryo. So if you're doing that, then the definition of recurrent implantation failure again changes. Okay, so there are several factors which are involved in this implantation, like maternal immune system, genetics of the embryo and parents, anatomical factors, and reproductive tract microbiome, endocrine milieu. These are the gross subheadings under which this review was conducted. The potential causes are at various stages of research. These causes are still undergoing research, and the final word is not out yet so in each category also we cannot say, we can only say that this is what the research says at this point of time. We can definitely not say that this is the cause or this is not the cause and this is the way to go or this is not the way to go. So that is where we stand now. So this review is published in December 2021 in Fertility Sterility. So it is the most recent review which is available on this subject. Okay, so like I said, immunological factors, genetic factors, anatomic, microbiome, and hematological and endocrine. Immunological factors, uterine immunological events. Like this has been an enigma, or we have been hearing about it on and off and reading here a bit about it here, there, and all that. And then we knew that there is this immunology is very, very important, and immunological, basically the implantation is a huge immunological event. The interplay crosstalk between the embryo and the endometrium is based on the immunology and immunological reactions. And only thing is, we didn't have a means or route to check what exactly happens in the uterine immunology, and we only were checking peripheral NK cells and then things like that, and saying that it is high or low. And because it doesn't correlate with the uterine NK cells, and several studies will report, some studies will report positive, means it is affected in recurrent implantation failure, and some studies may report that it is totally not relevant and not seen. But if we can look at uterine NK cells and the behavior of the uterine NK cells and the genetic expression of the uterine NK cells, so we can define the uterine immunological response. So that is where this review is addressing, and a few other things which can result in the alteration in this immunological reaction, like adenomyosis, endometriosis, chronic endometritis, insulin resistance, PCOS, and obesity have also been discussed. So several of these endometrial immune cells are tissue resident cells. And interestingly, all these are highly dependent on the hormonal environment. So ultimately, everything is interlinked. Okay, so estrogen levels, progesterone levels, and thereby these immunological cells, their number, type, and activation state, and then there is the genetic expression in that immunological cells, and all these are interlinked. And so you have to have correct estrogen levels, correct progesterone levels, and thereby have hope to have a good activation of this uterine immunological cells. But the picture totally changes once the fetal antigen enters, and this immune cell till then will be dependent on the hormonal environment and local inflammatory picture of the uterus. And then once the fetal antigen enters, then the interplay between these immunological cells of the endometrium and the fetal antigens will start, and then the whole the new story will start. Okay, so the most important cells are uterine NK cells. They interact with extravillous trophoblast. So this is the final interaction. These two cells are very, very important. These two cells are important for the crosstalk. Okay, these two have to interact with each other or talk to each other in a proper manner so that we have a proper implantation. So everything else, all the other factors act through disrupting the crosstalk between these two cells. Okay, there are different ways in which you can interfere with these two cells and the crosstalk between these two cells, but these two are the most important things. Yeah. So like I said, uterine NK cells. Uterine NK cells have genes called KIR, killer immunological receptor like genes. Okay, and they are the ones which interact with fetal HLA. Can you hear me? Hello?
Yes, ma'am. Good
Okay.
evening, ma'am. Yes, ma'am.
Yeah, in between for a few seconds we couldn't hear. Now we can hear you.
Okay. So these KIR genes are expressed by uterine NK cells. Okay, so they are the ones which interact with fetal HLA-C molecules expressed by EVTs. Like I said, uterine NK cells and EVTs. And in this, KIRs are the genes which are responsible for the interaction with fetal HLAs. They are highly polymorphic. This means that there will be different maternal and fetal genetic combinations in each pregnancy. Are you following me, or it's still confusing? Okay, so why I wanted to insist on that is because, okay, KIR genes are, are fixed for that woman. Of course, the expression can be polymorphic, but they are there. Like whatever type they are, I will explain the type. There can be, abnormalities in the KIR genes which are responsible for several pregnancy conditions. I'll explain again. And but they are, for that woman, that KIR types are fixed. But when you are looking at assisted pregnancies, and when you are dealing with, when you are putting in more embryos, and when you are using donor sperm or donor embryos, you have so much of HLA-C for that woman's KIR to deal with. Okay, so that is the point I got it from this review in the immunological. So it is going to be different. It is going to be difficult. The KIR genes of the uterine NK cells, they have to deal with so much of HLA-C load and wide variety of HLA-C load. So it really makes you wonder whether we should be transferring more embryos. It is probably better to transfer one good quality embryo so that the interaction is limited and then proper, and then you don't have abnormalities, and you are not straining and this care capacity, in fact. Okay, and when you have a different all this, that's actually, all of us know that when you are using donor programs, and maybe at higher risk for preeclampsia and things like that, that is probably because these KIR genes are not able to handle so much of HLA genes, so much load of HLA genes which are not related to the mother, and that is why there can be some kind of inhibition of the placental invasion, and thereby the pregnancy abnormalities can happen. Okay. So the genes, they belong to two haplotypes, A and B. A is a fixed number of 7 genes, and B has a variable number of additional genes. The presence of KIRB haplotype activating the KIR2DS1 receptor, which binds to HLA-C2, is associated with protection from pregnancy disorders. In contrast, women with KIRA genotype, they are at risk for pregnancy disorders. So this is what I wanted you to understand. Like there are uterine NK cells and the HLA-C, I mean the extravillous trophoblast, and these KIR genes and HLA-C. So that is where the interaction is happening at immunological level, which is determining a positive implantation or a resistance to the implantation. If there is high resistance and there is no implantation at all, if there is all levels of high resistance, there can be preeclampsias and IUDs and IUGRs and things like that. So that is what we understand. So that is the basis we have to keep in mind when we are going through the other factors also, which can disrupt this dialogue. In adenomyosis, what all does it do to disrupt this dialogue? There is altered estrogen receptor expression, lack of progesterone receptor expression, and secondary progesterone resistance. So like I said, estrogen and progesterone balance is very, very important for the uterine cells to become decidualized and the immune cells to become active and uterine NK cells to develop properly. So we need this progesterone for the uterine NK cells to express their genes properly. So if you don't have this embryo, means hormone, then the basic dialogue can be disrupted. And of course, there can be pro-inflammatory markers. A number of pro-inflammatory markers are there in adenomyosis, and of course, endometriosis also. And this means you can, I don't have to go through all this, IL-6 and ILB1 and IL-10, several of pro-inflammatory markers, and they can disrupt the activation of these immune cells and can release and can disrupt, can cause uterine NK cell dysfunction and thereby lower rates of implantation. So this is how the adenomyosis, we through steroids and inflammatory disruption can disrupt the uterine NK cell dysfunction and result in decreased implantation. Okay, endometriosis. In endometriosis also we have increased pro-inflammatory markers. Pro-inflammatory markers also can disrupt a proper endometrial lining developing, and then proper interaction between this uterine NK cells and then fetal extravillous trophoblast. Apart from that, it has been noticed that a lower frequency of activating KIR3DS1 and a higher frequency of inhibitory KIR HLA class 1 combinations were observed in women with endometriosis. So women with endometriosis have an abnormal gene expression of uterine NK cells. Not only that these inflammatory markers are disrupting whatever uterine NK cells that are there, they already have an abnormal gene expression. So people with endometriosis can have decreased implantation because of these mechanisms. Chronic endometritis, it's very easy to understand. This is inflammation, and again the dialogue can be disrupted. Insulin resistance, PCOS, and obesity. Okay, so in this, the interesting thing which I learned in this review is that because insulin resistance is there in PCOS people and obesity, and then all this diabetes and people with endocrine, all the endocrine abnormalities, and it can disrupt the progesterone receptor signaling. Okay, so I didn't know that before. So it can disrupt the progesterone receptor signaling, thereby affect the endometrial receptivity, because progesterone receptor is very important. Progesterone is the key hormone for implantation. Without progesterone, nothing will happen. And progesterone receptors, that is, they are very, very key. And then only the decidualization happens. of the endometrium, then only the uterine NK cells will come, then only the gene expression and HLA interaction, everything will come. So if we don't have the progesterone, that means progesterone signaling receptor, everything is disrupted because of this insulin resistance. We can have decreased endometrial receptivity in insulin resistance in these people. In obesity is also significantly associated with endometrial transcriptomic differences. So endometrial transcriptome, I'll explain to you, like which is tested in ERA. Like people with obese people will have abnormal ERA testing when compared to non-obese people, because of this, a lot of steroid hormone irregularities and insulin resistance, they have abnormal expression of the genetic abnormal endometrial genetic expression. And PCOS, in addition, PCOS will have aberrant cytokine profile and promote immune cell migration and thereby disrupt the dialogue there. And they have dysregulation of the endometrial expression of sex hormone receptors and co-receptors. So apart from this insulin resistance causing this this problem, the PCOS can have an addition of sex hormone receptor dysregulation plus enhanced cytokines or pro-inflammatory markers, which can disrupt the implantation. So PCOS alone, whether they are obese or not, and obesity alone also can cause these implantation profile problems. Okay, so that is immunological side we have dealt with in a short, and then genetic also I'll try to deal with in short. Genetics of the embryo, genetics of the mother and the endometrium. Of course, all of us know aneuploidy increases with age. 58% at 40 years, blastocysts are 58% of blastocysts at 40 years are abnormal, whereas 83% are abnormal at 43. Not only that, blastocysts of advanced stage are of poorer overall quality, even if they are euploid. That's what this review notices. And then implantation at the advanced stage is lower for euploid embryos when compared to younger people. So we might be thinking that as long as the embryo is euploid, and many a times we do observe that they do have a proper implantation, but when you study with so many people and the implantation advanced stage is lower, and blastocysts of the advanced stage, even if they are euploid, the quality is slightly lower. So these are the observations made by this review. As far as the embryo is concerned, and the effect of DFI could not be concluded because wide variation in the testing and reporting. They could not say whether this can cause aneuploid embryos or abnormal embryos. And we know that if the DFI is high, there can be a reduced implantation, increased miscarriage. We have seen in a few studies, and I don't think it was it could be proved in large studies because everybody tests DFI in a different manner at different times, and different interpretations are made, and different treatments are given for that. And so I don't think there is they are able to conclude whether how to interpret this DFI. Autosomal monosomies, haploides and polyploides, they do not progress to blastocyst stage at all. And whole chromosome aneuploides have very much less implantation potential. Embryos with segmental aneuploidy and maybe subchromosomal abnormalities and small abnormalities can go in for implantation and probably result in first trimester miscarriages. Okay. So are there any genes of the mother which are important or which can disrupt, disrupt the endometrial implantation? So here we have to be very clear. I just want to explain it here. abnormal genes are different, and the gene expression at the time in the implantation window is different. I'm sure many of you know this, because anybody can have abnormal chromosomes and some abnormal genes. There can be anything. So these abnormal genes, they are there all the time. Okay, when you can study in the mother those abnormal genes anytime. Whereas when you are looking at the implantation, implantation window, they are all normal genes only. They are supposed to be expressed only during the implantation and not other times. So there in ERA test and ER map and all those whatever those tests, they all determine to see whether those genes are being expressed during that time of implantation. So if I'm confusing you, please ask me again. I will explain again. And if you already know it, ignore me. So I'm talking about the genes which are abnormal, which can disrupt the dialogue between the endometrial cells and the embryo. There are quite a few genes which were studied, but again, large meta-analysis could not, could not prove that these genes are important and very significant, and we should be testing them in RAF. So we are not able to come up with such a kind of data. Of course, KIR gene abnormalities, this review is very sure. If you want to study KIR gene abnormalities, you can. And other genes, annexin, mucin, LAF factor, there are genes which are important and they are associated, but we don't know the importance of it and the magnitude of the importance. So we don't know whether we can make it as a standard practice to study the genes. The one thing which has been significantly seen as of now is MTFHR gene polymorphism, which has been in several studies have proved that it can be important in a failure. Okay, so this is what I was talking about. When we have a good endometrium with the help of good estrogen, and then there is progesterone, and progesterone is acting on the endometrium, we have a good endometrial, good decidualization of the endometrium. And during that time, we all know that the embryo can implant only during few days during the cycle, and or a few hours, or according to different studies, and that is called implantation window. And during that implantation window, the receptivity of the endometrium will be highly receptive. So all the cells will be decidualized, there will be good vascularization, and uterine NK cells are ready, and they are waiting for the fetal HLA-C to come so that they can interact and cause the implantation or whatever. So when we are looking at this ERA test, which is looking at there are several genes which get expressed during that time. Okay, so ERA test looks at more than 200 genes to see if the window of implantation is correct at that time. So if we choose to transfer, we all know that we test this, we make a HRT cycle, and then do an endometrial sample, and then send it to see if there is an expression of these 200 or 238 genes, and if they are expressed, we know that that window of we are correctly transferring during that window of implantation. There is a limitation to this study. This only says that it is the progesterone. It studies only the progesteronic activity. Okay, so if the progesterone has acted on the endometrium for so many days, so many genes have to become expressive. So if the progesterone has not acted for so many days, and it has to act more. So many genes are not expressed, so it will tell you give more progesterone or more days, something like that. So it is totally giving us how much progesterone we require to reach a window of implantation, but it is not telling us the competence of the uterine NK cells and the competence of it to interact with the fetal HLA-C. So that information we don't have it in ERA. So that is the limitation of ERA. And then there is so much cyclic variation, we cannot exactly replicate the same cycle where we are ERA done. So that is why the ERA is being limited now and not being used in means, of course, it's a personal choice, I guess, but I'm not using it. Okay, anatomical factors. We all know, I don't have to go into very much in details. Fibroids, polyps, septum, adhesions, and hydrosalpinx. I'll just briefly go through. And fibroids, how do they do? Increased venous congestion, diminished vascular supply, increased myometrial contractions, increased glycodelin level, reduced HOXA10 and IL-10 levels. Okay, so these are the mechanisms by which the fibroids can cause not only mechanical means, it can cause, it can impair the myometrial contractions and HOXA10 gene expressions and pro-inflammatory markers. So these are the ways by which a fibroid can diminish the implantation. So we should not think that it is only mechanical. Okay. So submucosal fibroid, we all know it reduces the clinical pregnancy rate, and if we remove the submucosal fibroid, we have improved outcome. Conversely, subserosal fibroid, there is no effect. So the controversy is there only in intramural fibroids. There are several studies which say that if you take out the intramural fibroid, you have a non-cavity distorting intramural fibroid. You can have a good live birth rate. There are equally good studies which prove and disprove this fact that intramural fibroids can also cause this glycodelin problems and pro-inflammatory markers and reduce the implantation potential. So both American Society and ASRM and Canadian societies, they advise against myomectomy for patients with asymptomatic non-cavity distorting intramural myomas, because there are equal number of studies which prove and disprove. However, myomectomy may be considered on an individual basis, considering the fibroid size, risks of surgery, and potential for pregnancy complications. Okay, like fibroid degeneration, malpresentation. So if you think that your patient is likely to go into all this, you may consider doing it, but not just that means as soon as you see an intramural myoma, you don't have to go jump in and do it. Okay, polyps are the most common uterine lesions implicated in RIF. Again, they do all these things: glycodelin, HOXA10 expressions, increased IL-10 levels, insulin-like growth binding factors, tumor necrosis factors. And it has also been observed that it's not just the polyp sitting at one corner. When there is a polyp, all this the whole uterine environment is disrupted, and histological abnormalities have also been identified in the endometrium of means cavities having the polyp. So it is not that corner which is affected, the whole endometrial milieu is affected because of that. Okay, so I don't go into this. If you remove the polypect, of course, again, we have a in an IUI cycles, they have a good RCT, which shows that once you remove the polyp, there is a twofold increase in pregnancy. For IVF, surprisingly, there are no RCTs. But retrospective studies did not show improvement in CPR or LBR with clinical significance. Additionally, meta-analysis data suggests that diagnostic hysteroscopy alone improves reproductive outcomes after IVF, regardless of uterine pathology. So, as far as IVF is concerned, we don't know whether a polypectomy is doing us a favor, or just a diagnostic hysteroscopy is doing us a favor. Similarly, in septum also, we think that removing the septum should increase the clinical pregnancy rate, and we see it in our practice. But there is a first and only RCT which was published in April 2021, which showed there is no difference in ongoing pregnancy rate, LBRs, and preterm delivery days. But there is a lot of criticism in this trial saying that they have not mentioned the length of the septum they have included. Probably they've included very normal uteruses and just a small septum, so that is why it is not reaching clinical significance. So ASRM currently says it is reasonable to consider hysteroscopic septoplasty in infertile patients. Okay, so you can go ahead, and as far as this polyps and septum are concerned, even though you don't have a good RCTs in IVF, I think we can go ahead and remove them. Additions like Asherman syndrome. Intrauterine additions have been reported in 8% of patients with infertility, 38% in RPL, and women with Asherman syndrome, 43% had infertility. All these are a little bit jumbling of numbers. Ultimately says that it is involved in infertility as well as RPL. And although there are no high quality RCTs evaluating hysteroscopic radiculolysis, multiple cohort studies suggest that surgical treatment improves the pregnancy rate from anywhere between 32% to 81%, depending on the addition severity. But we have to be careful. Even though pregnancy rates are favorable, women with Asherman remain at risk for preterm birth, abnormal presentation, and uterine rupture. Hydrosalpinx. So we, according to our data, 50% reduction in implantation rate in women undergoing IVF. So there are 3 treatments which have been considered in this review: salpingectomy, disconnection, aspiration, and sclerotherapy. Salpingectomy, even though it is a gold standard, just proximal tubal occlusion is also comparable to salpingectomy. So that is what this review has observed. And okay. And aspiration and sclerotherapy also, instead of doing nothing, we can do aspiration and sclerotherapy at least. So that's what this review says. Of course, the gold standard is salpingectomy. Microbiome. Okay, this sentence I liked, so I copied. The human microbiome has been established as an essential, interactive, and coexisting part of normal human physiology and hemostasis. The term microbiome refers to the whole set of microbes, including bacteria, viruses, phages, archaea, fungi, and depending on the composition of different local microbes, they exert a diversity of functions ranging from metabolic and epigenetic to immunological. Importantly, the continuous dynamic balance between human body and microbes is associated with the human state of health and disease. So this is why the microbiome is coming in a big way. It is there everywhere, and we have to live in balance with our microbiome, and we cannot eliminate microbiome from any system. Unless we have a perfect balance of this microbiome, our health is not possible. Anyway, I think I'm crossing my time. We all know that the vaginal bacteria is mostly, if healthy vaginal bacteria consists of lactobacilli, and we were thinking that even the uterine microbiome consists of predominantly lactobacilli. Good uterine microbiome means it should be lactobacillus predominant, and bad uterine microbiome should be non-lactobacillus predominant. So that is what was being studied in many studies. But recently they wanted to see whether that is the case, and then hysterectomy specimens and all the other specimens where we are not testing through the cervix, avoiding the contamination, and they found that it is not lactobacilli, and there are several other bacilli which are more prominent in in the uterus. And so again, now we are at a fix to say what is a good microbiome in the uterus and what is not. We don't know. Lactobacilli are good in vagina, so we don't know whether that is true in uterine microbiome. So that is where this review stands. Okay, like as said previously, everything is under research. Final word is not out yet. Okay, but of course, chronic endometritis, we know that there is inflammatory pro-markers, and whatever is the microbiome which is causing chronic endometritis, that can decrease implantation potential. That is for sure. Okay. Okay. Hematological. Even though we know that the implantation is an immunological factor, ultimately these after these immunological interactions have happened and the endometrium becomes adherent and starts invading, it is the vascular factors which come into play, and all those things that vascular acceptance and vascular invasion, all those things should happen for an implantation to occur. And these thrombophilic factors acquired or inherited theoretically can disrupt that vascular dialogue and can disrupt the implantation. But these meta-analysis is not able to show that inherited thrombophilic factors are significantly affected in women with recurrent implantation failure. So there is a retrospective study involving 594 women with seven failed IVF cycles, 7 failed. And compared with controls, show no significant impact of this inherited thrombophilias. Similarly, APL also. APL, of course, it's hugely implicated in recurrent pregnancy loss, but as far as recurrent implantation failure, it is not reaching a clinical significance in 2 case controlled studies. So these thrombophilias, maybe they are important. I'm sure they're important, but we don't know how important and whether testing them is going to give us any idea about recurrent implantation failure. So the Canadian Fertility, Sterility and Andrology Society released a 2020 clinical practice guideline stating that testing these things in RIF is not recommended because there is insufficient evidence. Okay, oh, this thing is come here. The slide has got mixed. Like I said, the hydrosalpinx fluid. Okay, fine. Finally, we reach endocrine. Endocrine, of course, we know estrogen. We know that estrogen is very, very important for the endometrial proliferation to happen. Progesterone for decidualize, it means the secretory phase to enter into the progesterone, and stroma and glandular, both are affected, both are changed by the progesterone, and both the changes in stroma are different, and changes in the glandular phase is also different based on the number. The stromal change depends on the level of progesterone. Glandular change depends on the number of days of progesterone. So that is where the progesterone is very, very important. Not only the level, and the days also are important. Estrogen probably not that critical about the dose and the days, but progesterone we are very, very particular that the dose and the days both can influence that stromal and vascular composition of the endometrium. Okay, and of course these are responsible for the endometrial cycle. Luteal phase defect. When we were young, it used to be talked about in a long way. Excuse me, can you mute? Excuse me, can you mute? Okay. So luteal phase defect we used to, but because it was not, it could not be proved, and because it changes from cycle to cycle, that was not that was ignored totally. But nowadays we know that. nowadays we know that luteal phase defect does
கம்ப்ளீட்டா க்ளீன் பண்ணுங்க. அந்த கார்டனரை வர சொல்லி இந்த செடி எல்லாம்.
Okay, thank you. Of course, iatrogenic luteal phase defect. This we see in stimulated cycles like in IVF. So how do we diagnose? Biopsy used to be the good old day, and nowadays none of us do, and this review just mentions it. The other tests are these, like ERA, which sees 238 genomic expression, which is an RNA-based platform. Window of implantation test, polymerase chain reaction of 11 genes, which is tested in the natural cycle. So if you want to test to see if there is a good window of implantation in a patient just coming up and in a natural cycle, if you want to detect or diagnose a luteal phase defect in that person per se, not iatrogenic, then we can go for this test. ER map again is a polymerase chain reaction of based detection of 40 genes. Okay, this will see whether that particular endometrium has reached window of implantation at that particular time when you are testing, of course. Hematological factors, inherited and acquired thrombophilia. So, okay, I think I'm done. Thank you very much. Thank you for patient listening.
Thank you, ma'am. That was a very vivid presentation. You have done a lot of slide work, I think, in the last 2-3 days.
2 hours.
Yeah. Oh, 2 hours is not just too bad. We'll keep the discussion at the end after finishing the second presentation.
Yeah.
I call.
Sorry, I've taken more time. I think I should have finished faster. Sorry.
Recurrent implantation failure will anyway take that much time, ma'am. It is expected. I call upon Dr. Aishwarya for the next talk. Aishwarya, are you there?
Yes, ma'am, I'm there.
Yeah.
I'll start.
Yeah.
Okay, can you see my slides, madam?
Yeah, we can.
Okay. Good evening, one and all. I'm Dr. Aishwarya from Chennai. I should thank Dr. Indumathi ma'am. She was my teacher in FNB at MMM. She taught us a lot in fertility, and she was the one who asked me to join this group belonging to Salem, which is doing a wonderful job of conducting weekly journal clubs as a pure academic session. So today I'm going to present this journal from fertility sterility, novel therapeutic options for the treatment of recurrent implantation failure. So this journal, as you all know, is Fertility Sterility, and editor-in-chief is currently Kurt Bernhardt, and it's called as the Red Journal, and it is the official journal of ASRM and many other societies in the USA. So this journal was published in December 2021 and was authored by Turosi et al. And the place of study was in Columbia University, New York, and it is a review article. Recurrent implantation failure, as madam told previously very elaborately, there is not still a single correct definition. However, while we were fellows, we used to follow this definition by Kugler et al. Recurrent implantation failure refers to the failure to achieve a clinical pregnancy after a transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40. There is no standard accepted definition. Both clinicians and patients are desperate to find something different. The evaluation and management is often flawed because of the lack of standard criteria of RIF, lack of exclusion of aneuploid fetuses, lack of stratification for factors such as number of previous transfer. The post-intervention treatment can result in pregnancy by pure chance when patients are used as their own control, which is usually done for any trial as far as recurrent implantation failure is concerned. And the current meta-analysis also have a results which are from the heterogeneous patient population. So here in this article, they have reviewed 3 most promising new therapeutic option. That is the intrauterine infusion of peripheral blood mononuclear cells, intrauterine infusion of platelet-rich plasma. I think that is going on in many places. And the third one is subcutaneously administered granulocyte colony stimulating factor. So first, let us in the first heading, peripheral blood mononuclear cells. So why that was taken in first place? So just a small overlook. So this is the blastocyst. So this is how it implants: apposition, adhesion, invasion, and then finally decidualization. There are a lot of selectins, MUC1, and many other ligands, pinopodes. And once the implantation process starts, there would be excess number of macrophages and uterine NK cells and LIF1 and many other such factors, cytokines and macrophages. So this is hypothesized that the patients with RIF may be unable to recruit the necessary lymphocytes which are needed for successful implantation. So some amount. Yeah, I just unmuted myself. So there are some necessary lymphocytes which are needed for successful implantation. And here comes the role of peripheral blood mononuclear cells, which contain both T and B lymphocytes and monocytes and induce the production of cytokines, interleukins, and growth factors. So how we are preparing the peripheral blood mononuclear cell? According to the study, what they do is take this blood sample 2 days prior to the embryo transfer, and then they process it on a specific method. Usually it's centrifugation. Then it is collected from the interface layer and washed with a particular medium called as 1640 medium, and it is suspended with SBS incubated with 10 international units of HCG. So this is how they do it. And it is cultured for almost 24 hours. In certain studies, it has been cultured up to 72 hours also prior to the FET or the fresh embryo transfer, depending on the type of transfer. So this is how, this is just a pictorial representation of whatever I had told. Collect the blood, centrifuge depending on the method. Then collect the peripheral blood mononuclear cells, incubate them with HCG. This is the most important part. And then transfer it 24 hours to the prior scheduled embryo transfer. So it is usually done 24 hours. So why this HCG is needed? This was, it was seen that HCG activated PBMCs and enhances the secretion of cytokines and chemokines. So this is the, what are all the studies that have been done in this method? This is the tabular column. So out of this, 3 were only prospective studies. So the weightage of the study is little less. 3 were RCTs. So I have expanded it, and I will explain it in detail also. And when we see all these studies, we see that the number of participants have been very limited, except in 2 studies. And the outcome reported, it's all favorable, that if you use peripheral blood mononuclear cells prior to the embryo transfer, the clinical outcomes such as clinical pregnancy rates, implantation rates, and in certain studies, the live birth rate also have been said to be improved. Now, let's look only at the highest quality of evidence in this, which have been done for this method. So the RCTs. So 3 RCTs have been done, 2 in 2016 and 1 in 2019. In the first RCT, the number of participants have been very less in each arm. And in the next 2 studies, it's almost 200 and 138. And they saw that the results, the clinical pregnancy rate, the implantation rate, everything improved when this peripheral blood mononuclear cells were used prior to the embryo transfer. So they found a beneficial effect on both the clinical pregnancy rate and live birth rate according to the recent meta-analysis, which was a combination of these 3 RCTs. So now what is the current consensus? So although the studies are small with heterogeneous study population and differing preparations of protocol and various treatment protocol, we are still not, we just know that the studies are promising, but we still don't know the exact reason. I'll just go back to the 2 slides before. I forgot to tell you something. In this study, in these 2 studies, what happened is they have in Madkor et al. And Yu et al. They have done it 24 hours prior to the scheduled embryo transfer. And in the first study, they have used incubated with HMG. In the second study, they have incubated with HCG. And in the third, they have incubated with corticotropin releasing hormones for 24 hours. So how we can equate all these studies together, and we cannot come to a conclusion because these are the highest levels of evidence, and each of them have studied different types and with different kinds of different methodologies. So it is not possible. So that is why the studies do not have a good way. The meta-analysis does not has not come to a conclusion. So the next one is the intrauterine infusion of platelet-rich plasma. I think many centers are doing this nowadays. So why a platelet-rich plasma? That is because a platelet-rich plasma is basically a highly concentrated preparation of platelets in a small volume of plasma. And it has a lot of growth factors, platelet-derived growth factors, transforming growth factor, and so many other growth factors. These are stored within the alpha granules of the platelets. Okay, so what happens when you process the platelets, it gets activated, it releases the granules, which can be used for the differentiation of cells, angiogenesis. So usually it is being used in cases of thin endometrium. It has been studied in cases of thin endometrium. So how we have to process is around 8.5 ml of venous blood is taken with a acid citrate solution, then 1200 rotations for 10 minutes, and then again centrifuge at 3300 for 5 minutes to separate the plasma and obtain PRP, which will contain platelets about 4 to 5 times higher in concentration, and then 0.5 ml of PRP is instilled prior to the embryo transfer. So now it is usually done 48 hours done before the embryo transfer according to the studies. Only single transfer 48 hours prior. So now these 2 RCTs, again going to the highest level of evidence. These 2 studies were done. So I've just summarized it in the tabular form. Nazari et al. And Zamanian, both of them are Iranian studies. Both of them had a very similar population. 3 or more high quality blastocyst transfer failure. However, PGTA was not done. And the number of participants in the first study is 138, second study is 98. So they found an improvement. In the first study, they found only an improvement in the biochemical and clinical pregnancy. In the second study, they said that there was an improvement in the clinical pregnancy, implantation rate, and ongoing pregnancy rates also. The third thing is granulocyte colony, that is GCSF. So subcutaneously administered GCSF. So this is actually a glycoprotein which is produced usually in our blood cells, immune cells like monocytes and macrophages, and it has been investigated as an in vitro fertilization adjunct, and can be administered either locally or systemically for women with thin endometrial. So as like PRP, it was also it is usually used in cases of thin endometrial lining, so that there would be a differentiation of cell basal layers. That's what is the proposed theory. So similarly, it has been used for recurrent implantation failure because it produces the localized lymphocytes and macrophages. So there are 2 studies again I have summarized here. The first study used the subcutaneous GCSF, and last 2, the next 2 studies, there were 2 studies done in 2020, which studied the local administration, that is intrauterine administration of GCSF. They have found that 1 hour before the subcutaneous, if we use it 1 hour before the transfer subcutaneously, it improved the clinical pregnancy rate and the implantation. The results were improved. However, on the local administration, there was no effect found. So the reason that is proposed is there could be a beneficial effect of GCSF due to the oocyte maturation and embryonic development, but not due to the local action on the endometrium. So this is still not very clear how things are going. So then coming to the final thing. So there are other methods that have also been proposed, novel methods, not with high quality evidence: intralipid, intravenous immunoglobulin, heparin, all by modulating the uterine NK cells or by modulating the local milieu, as ma'am had in detail in the previous presentation told, lot of the local uterine factors, they are modified, and heparin exclusively acts as an immunomodulator. So now coming to intralipids, actually this is a study what I would just tell you about the study which we had done in M. So the intralipid is actually a fat emulsion made of soybean oil, glycerin, phospholipids, and it reduces the uterine blood, peripheral blood NK cell activity and suppresses the pro-inflammatory cytokines. So this was the study which we did in M. Dr. Indumathi was the one who encouraged me to do the study. So we studied the effect of 20% intralipid infusion prior to frozen embryo replacement with good quality embryos. So there were 2 arms which we studied, whether we can use it in previous 1 or more failures or in first transfer. And we had almost 123 women with previous 1 failure and 60 women with first transfer. And it was done between 2017 to 2018 and as a prospective interventional trial. What we found out is if you had at least previous 1 failed transfer, there was improvement in the ongoing pregnancy and clinical pregnancy rate. In RIF, more than 2 failures, that was our criteria. There was an improvement in the clinical pregnancy rate and the ongoing pregnancy rate. However, there was no effect on the miscarriage rate. And first transfer, there was no improvement. So that is the conclusion was that it is definitely helping in cases of recurrent implantation failure. This was in the study which we did. So what is the lacunae we have still in the novel methods is we really don't know what actually works. They are all based on heterogeneous studies. Everybody has given a different definition of implantation. One has done a 3rd day transfer, one has done a 5th day transfer. Some have taken 2 as previous failures as control. Some have taken 3 previous failures as into inclusion. And so that is not. Maybe in the future, pre-genetic testing for aneuploidy can become the game changer if it is done in large scale, especially in targeted populations like recurrent implantation failure over 35 years of age. So all couples suffering from recurrent implantation failure should be provided emotional support and reassured. And the majority, over 95%, will actually achieve a pregnancy with continued. So we have to tell the patients that they might need 2-3 cycles of IVF and continued transfer of high quality embryo transfer, preferably blastocyst transfer, in case they had this problem. Thank you.
Thank you, Aishwarya. Now we can go for the questions. If anyone has the questions, they can ask. So, Dr. Aishwarya, after your experience with intralipids, are you using it in the hospital where you're working, or what other practice are you, out of these evidence-based 3 ideas which they have given, anything we are using now? Anybody else in the forum also can answer this.
Currently for RIF, ma'am, I have personally not used PRP, but the other consultant does use PRP. After I told about our study, the consultant has started using intralipids, and there is definitely an improvement, especially in cases of previous transfer. So it's like although there is no documented evidence of natural killer cells or anything, but in cases of like some patients, even after donor transfers, they have 2 failed transfers, two failed DETs. So we have seen practically that it is improving, madam.
Dr. Vani, ma'am, you want to say something? Yes, ma'am.
Good evening, madam. I have one doubt, madam.
Yeah.
To Dr. Vani, ma'am. Madam, good evening, ma'am.
Good evening, Vijay Lakshmi. Hi.
Hi, ma'am. For hydrosalpings, do you have any experience regarding if you put Assure, madam, occlusion, proximal occlusion of tube after that transfer?
I only read about it, but I have not done it, and I don't have
Only sclerosing agents only you applied, madam?
No, for hydrosalpinx, I either go for salpingectomy or occlusion. So those are the only things I do. I have not tried aspiration sclerotherapy or this blocking through hysteroscopy. I know there are few people who are doing that, but somehow I tried blocking, and I thought uterine milieu will change if we are using Assure, it's fine, but if you are using anything else like cautery and all that, so I don't know how effective it is going to be, and I was not very convinced, so I am not using it at present.
Thank you, ma'am. Madam, Indumathi, madam, what is your experience, ma'am?
See, this Assure thing will not block the tube completely if it's going to be a big hydrosalpinx. See, it heals by fibrosis and causes the block.
Okay.
So it can be used. It initially was used as a contraceptive method for a normal tube of a uniform caliber. See, in hydrosalpinx, we won't know if it is more close to the cornual end, you can't go and block that area, and it may not be complete also. And fibrosis occurs to a larger extent more towards the cornual end and also a little bit towards the the interstitial part. So, and there's also a long gap between how much of fibrosis is formed, and we don't have any method to check how much is formed. In case we do a self-injectomy, we have the evidence in front of our eyes, we have removed it. Another thing is when you do a tubal clipping, in the sense you are disconnecting the medial end, then also you will be very sure that you have removed it, and also salpingostomy. But for this, we don't have any evidence that it has blocked. You will have to do a tubal check again. You have to do a HSG or you have to do a dye test again, just to make sure nothing is coming out on both the sides.
Oh, thank you. Madam, for chronic endometritis 3D 138 testing you are doing?
We are not doing it right now. We are depending on the hysteroscopic findings. And a few months back, we had a discussion here in this forum only about a journal which said that you don't really have to test it. And if you have hysteroscopic findings, you can go with that, and then you can confirm your diagnosis and then go ahead and treat it. So I'm not being bothered with that. So hysteroscopic findings, we go ahead with it.
Okay. Thank you, ma'am.
Okay. Anybody else has any comments?
I have a doubt, madam. Like any seniors in the forum can answer. What you think will be the role of PGTA in cases of recurrent implantation failure?
See, now the definition of recurrent implantation failure itself is failure of 2 euploid embryos not implanting. So which means that every person who's before defining that they are having recurrent implantation failure, you're supposed to do an euploid embryo transfer. So now at present, recurrent implantation failure is very fluidy, because even a cell stage embryos, when they do 3 embryo transfers 3 times, then again they go back to the old definition of 10 embryos again. So that doesn't hold true anyway. And we can't be transferring 3 blastocysts to prove that they are having recurrent implantation failure, because a euploid single blastocyst twice is the new definition for RIF now. It can be 2 IVF cycles with an unchecked blastocyst, or if you do a PGTA, then it is only 2 euploid. So it is coming a big way now. I think the future of PGTA is more promising now, because at least you can define that she's RIF if you have put 2 euploid embryos. That is 1 euploid embryo at a time. So 2 transfers.
2 transfers.
Yeah,
yes. That is the definition of RIF now. This has come in the same series of articles which you have read through. If you go down that page, you have the same article which says this.
Okay.
Yeah.
Okay, ma'am.
December 2021 fertility sterility, there is an article which says that once you transferring euploid embryos, your RIF should be less than 5%. So that means that majority of RIF is because of course, that is the only study which says that. The other studies have not confirmed that finding. But if you are going with that, then a majority of the RIF is because of aneuploidy. So that means you have to do that. That probably is the major intervention which we have to do. All these other interventions come only in that 5%, where you are transferring euploid and then failing, then probably you are looking at all these intralipids and all those things. So, that way, if you are going with that study, then we are looking at
recurrent implantation failure. The definition applies as long as we don't do the cell stage embryos. Like if we keep doing the cell stage embryos, 8 cell stage embryos, then if, for example, if you have done 3 IVF cycles, cell cycle with all the time it was only 8 cell stage, I think the definition is slowly changing because you haven't even tried a blastocyst. So if you don't try a blastocyst, it doesn't even come under recurrent implantation. So I want to encourage everybody, if one cycle has failed with the cell stage, then definitely they have to take it to the blastocyst to overcome the fear of cancelling an embryo transfer. So once the blastocyst doesn't work, then starts the workup of recurrent implantation. I think with cell stage, we should be going more forward towards blastocyst.
Okay.
That's a question here, Dr. Indu.
Can you read, ma'am? Because
in intrauterine installation of PRP 48 hours before ET, will the endometrium get disturbed?
No, it won't get disturbed. Actually, this there is something called this activated PRP was coming up a long way in 2016. It was introduced. Now it is called as Ferticera. So those company people used to pester us to use those. So what we did is we used that product on the 5th day of the period and then 10th day of the FET cycle, and then 48 hours before the transfer. So I did it on around 11 patients, very small number. And out of the 5 of them had a good endometrium. I didn't study about the CPR or the implantation for them because I used for thin endometrium. So though the pattern was very thin, around 6 mm, I used to get a triple line pattern. So I used to go ahead with transfers even in 6 mm for refractory endometrium. So when I observed 48 hours before the transfer, nothing happened. The implantation did occur. And out of the 11, I think four were pregnant. But then we discontinued because of the cost. It was very high at that time. Now they have revised the prices, but I'm not using it anyway. So nothing happens to the endometrium even if you use, and we also did a study on intrauterine installation of HCG at the time of the FPT. That also we did, but the results were not great. We tried everything on the endometrium before implantation. And also we did etosiban. Etosiban for 2 previous IVF failures, but that was not promising because we didn't have a clinical number and it was not clinically significant. So
we have an etosiban fan here, Kavita.
We used to give atosiban for previous 2 failures. At least 1 failure also we used to give atosiban because we had to get a number. So we presented and we also got the best paper in 2016 in ISAR, but our results were not that great. So we stopped that also. And slowly we started to stop everything. Steroids, low molecular weight heparin, and ecospirin during stimulation, everything we stopped actually.
Steroids.
One more question, ma'am. Any seniors? Ma'am, there is a patient who had a DET with everything was fine. We had transferred 2 hatched blastocysts for her. She's a young patient, uterine, no uterine factors, no tubal factors, nothing. So what would be the next step? Would ERA be a next step because she cannot have more transfers? Or will it be like a PGT followed by a transfer? What will be the next step?
This is the first transfer for her, right?
Second DET.
Second DET with 2 embryos each time.
2 hatched blastocysts.
Then maybe you should do an ERA and see if the receptivity is okay. Has a histro been done for her?
Hysteroscopy is normal, madam.
Yeah, maybe you can do an ERA or you have to counsel her about PGTA.
PGTA. Okay.
Yeah, PGTA and ERA.
And in case we have only 2 sets of embryos, madam, in some patients, and 1 transfer is failed, despite it being good and all the female factors being good, Does it make sense to do ERA at that time
Yes,
prior
we
to the
can
next
do.
transfer?
We can do. At least see PGTA again. You have to plan a cycle and give them a few embryos for them to biopsy, or else even they can't do anything. But with 2 embryos in hand, at least you can check the receptivity and place them.
Okay, so there is no strict rules for ERA. At least one
No.
failed transfer.
We can do. We can do.
Okay, okay, madam.
Yeah, we don't believe in ERA much, but I was doing quite a few ERAs, left, right, center, then I've stopped. I try and look for other factors and, probably, I don't know. I mean, somehow I'm not going for ERA.
We have left everything actually. Only 2 we are holding on to. One is PGTA and another is ERA. So we don't know when we are going to discontinue this also.
I thought PGTA has gone and coming back again.
Yeah, it's coming, ma'am. We are doing for
and now many people are
many people are also asking for it.
Yeah.
They want
hysteroscopy advised, no, madam. For
Yeah.
remaining all are gone, it seems.
But they have done the hysteroscopy also, and yeah, we have to do everything possible, and
some recommendations all are process only. No. But we are giving all in spite of. But if you won't write now, madam, if we'll get negative result, then they may point out. They will go and consult another doctor, and you didn't give.
Yeah. Even for intramuscular injections, they used to fight among themselves. That patient unfortunately becomes positive, and one on butanol becomes negative. And they will say that patient got all the injections, but you never gave me any. So that's also a big problem.
Why you gave 2 injections to her, 1 injection to me?
Yeah.
Kavita, you want to say something? Madhu? Okay.
Madam, both of the speakers are very nice presentation, and really very informative.
Thank you.
Thank you, madam.
Meenakshi says PGD accuracy varies for every single chromosome, and the sensitivity varies a lot between the labs. Mosaicism is not detected at all. POC analysis also is good for RAF patients to validate the cause. Thank you, Meenakshi. So if there are no more comments, can we wind up?
Yeah, yes, ma'am.
Yeah, ma'am. Thank you.
Thank you.
Okay. Thank you very much.
Thank you all. Thank you all. Thank you all for joining.
Thank
you, ma'am.
Good night.
Good night. Yeah.
Thank you.
Rahim?
Ma'am?
Wind up.
Okay, thank you, ma'am. Good night.